In this video lecture, we'll review different biological treatments for depression, including pharmacological treatments, as well as other kinds of biological interventions. We'll start by talking about pharmacological treatment options for depression. There are several different classes of antidepressant medication that work in different ways, but through a similar mechanism. So all of these different types of antidepressant medications work in general by increasing the availability of serotonin or other monoamines in the synapse. The earliest developed class of antidepressant medications are the monoamine oxidase inhibitors, or MAOIs. Monoamine oxidase is an enzyme that breaks down monoamines in the synapse. So monoamines include neurotransmitters, including serotonin, dopamine, and norepinephrine. So as you might expect from the name, monoamine oxidase inhibitors inhibit the function of this enzyme. So by blocking the breakdown of these monoamines in the synapse, monoamine oxidase inhibitors increase the level of monoamines that are available in the synapse. So they block this enzyme that breaks down the monoamines and lead to increased availability of serotonin, dopamine, and norepinephrine in the synapse. Monoamine oxidase inhibitors are no longer as commonly prescribed as they used to be. They can have some pretty significant side effects, including cognitive symptoms like difficulty concentrating or confusion, also physical symptoms and sexual side effects. They also can require some pretty significant lifestyle changes. So for example, individuals taking MAOIs need to avoid eating certain foods like fermented foods and need to avoid drinking alcohol because there can be very dangerous side effects from consuming alcohol or certain foods while taking MAOIs. And they can also have some serious interactions with other medications. So due to these concerns, they are less widely prescribed. Another older class of antidepressants are the tricyclic antidepressants. Tricyclic antidepressants work by blocking the reuptake of serotonin pretty globally across different kinds of receptors and throughout the brain. And by blocking the reuptake of serotonin, they increase the availability of serotonin in the synapse. So much like the MAOIs, they are increasing the availability of serotonin. They're just doing it through a different mechanism. Like the MAOIs, the tricyclic antidepressants can have some pretty significant side effects. And another concern with tricyclic antidepressants is that they have relatively high lethality. So a relatively low dose of tricyclic antidepressants could be fatal. So this can be a concern if you have patients who are experiencing suicidal ideation or who are at risk for suicide. If a typical 30-day prescription for an antidepressant could contain a potentially lethal or dangerous dose, this would be a potential concern in prescribing this medication. So currently, the most widely prescribed class of antidepressants are the selective serotonin reuptake inhibitors, or SSRIs. As the name suggests, these work by inhibiting the reuptake of serotonin selectively. So they inhibit the reuptake of serotonin at specific receptors and in specific regions of the brain. So compared to the tricyclic antidepressants and the monoamine oxidase inhibitors, they have lower levels of side effects, and they are also, they have lower lethality. So it's not that SSRIs are more effective compared to MAOIs or tricyclic antidepressants. That's not the reason that they tend to be the most widely prescribed antidepressants. They're preferred as a first-line treatment primarily because of the lower side effects and the less severe side effects, and also because of their lower lethality, so they are more safe. There are also other kinds of antidepressants. Some of them we understand the mechanisms by which they work, others we are not quite sure, but in general they all seem to work by increasing the availability of monoamines in the synapse through various mechanisms. So one example are the serotonin norepinephrine reuptake inhibitors, or the SNRIs. So similar to the SSRIs, these work by blocking the reuptake of serotonin, but they also block the reuptake of norepinephrine. They tend to have a similar side effect and safety profile to the SSRIs, so they're also relatively widely prescribed as a first-line treatment currently. So again, when we are thinking about the efficacy of these antidepressant treatments, we see that response to these various classes of medication, we tend to see about a 50% response rate regardless of the class of the medication. So whether we are looking at MAOIs or tricyclic antidepressants or SSRIs or SNRIs, about half of individuals who take these medications will experience a 50% reduction in their symptoms of depression. Remember, that's how we characterize treatment response. And across all of these classes of antidepressants, this is significantly better than placebo. So all of these various classes of antidepressant medication are effective for the treatment of depression. We tend to prescribe SSRIs and SNRIs as our first-line treatment because of the more favorable side effect profile and the lower lethality. However, MAOIs and tricyclic antidepressants are also effective treatment options and may be used for patients who don't respond to SSRIs or SNRIs, or who have other reasons that they cannot take SSRIs or other classes of medication. There are also other biological interventions to treat depressive symptoms. One is bright light therapy. This is often used for seasonal affective disorder, so that is a depressive disorder characterized by recurrent episodes of depression that have their onset during a specific time of the year and then remit at other times of the year. Often the depressive episodes are occurring in the winter months, but it can also be used and has demonstrated to be effective for other depressive episodes. So in bright light therapy, an individual looks at a light box, just like the one you see on the screen, first thing in the morning, and these light boxes have a specific level of brightness. So you need to look at the light box with your eyes open. So this is not a basking like a lizard, not like a tanning bed kind of treatment, but the individual turns on the light, and you do it first thing in the morning. So it's pretty common for bright light therapy to prescribe someone and say, you'll look at your light box for 30 minutes a day, first thing, with the eyes open. And what this does is there are photoreceptors in your retinas that project to the pons. That's that region of the hindbrain that is closely involved in regulation of arousal and circadian rhythm. So exposure of these photoreceptors to this bright light for a sustained amount of time regularly every day appears to help regulate arousal and mood by stimulating these photoreceptors and helping regulate sleep and arousal and mood via these projections to the pons. So bright light therapy can be a great option for people who are not able or willing to take medication. Other biological interventions include electroconvulsive therapy. Electroconvulsive therapy is often viewed negatively, and people have many negative associations with electroconvulsive therapy. However, the way that it's currently used looks a lot different than the stereotypical and historical way that ECT was practiced. So currently, electroconvulsive therapy is usually given on one hemisphere of the brain. So historically, ECT was given bilaterally and at a much higher intensity. And this had a tendency to cause side effects. Most predominant was short-term memory loss. So the current way that electroconvulsive therapy is done is at a much lower intensity and on a single hemisphere, and is associated with much lower side effects. And there's clear evidence that electroconvulsive therapy is an effective treatment for depression and can be particularly valuable for individuals with treatment-resistant depression, so who have severe depressive symptoms that's not responding to other interventions. As an example, these are results from a study of 10 patients with severe depressive symptoms. These had treatment-resistant depression, so their depression had not responded to a wide range of other interventions, including pharmacological interventions. So in this graph, you can see their pre-treatment depressive symptoms were high. So these were assessed using an interview called the Hamilton interview to assess depression. Their pre-treatment scores were above 12, which is considered the threshold for clinically significant depressive symptoms. And then after receiving electroconvulsive therapy, their symptoms had reduced significantly. So they are still above threshold, but we have a really significant treatment response, which is particularly notable given that these are patients who previously had not been responding to other interventions for depression. So electroconvulsive therapy is typically not a first-line treatment. It is more invasive. It can have more severe side effects than other kinds of treatments. But for individuals who are not responding to other interventions and who are experiencing significant depressive symptoms, this can be a very effective treatment option. Another biological intervention that can be used particularly for treatment-resistant depression is deep brain stimulation. So in deep brain stimulation, rather than stimulating the brain using electrodes as we do in electroconvulsive therapy, where we do it by applying electrodes to the outside of the head at the temples. Typically, we're doing that in a hospital setting. In deep brain stimulation, we actually implant a small electrode in the brain that continuously stimulates a specific region of the brain. So many of the studies of deep brain stimulation have been done implanting electrodes into the nucleus accumbens. That's part of the limbic system. So here are results from a case series of deep brain stimulation that was used to treat 6 patients with treatment-resistant depression. And in this graph, you are seeing the scores on a measure of depressive symptoms. It's that same Hamilton interview for depression that was used in the previous study. And for each patient, you are seeing their depressive symptoms over time. So the first bar is showing their pre-treatment depressive symptoms, and then the subsequent bars are showing their depressive symptoms every month up through 6 months after the surgery. And what you can see is a pretty consistent pattern that nearly all of the patients experienced a dramatic reduction in their depressive symptoms that is then maintained over a 6-month period of time. We do see that not all patients respond. So patient 4, we saw a small treatment response, but then their symptoms recur. So not everyone responds to deep brain stimulation. But for the majority of these patients, we see that deep brain stimulation was an effective treatment for their depressive symptoms, and that they experienced a sustained improvement in their depressive symptoms. So again, this is particularly notable because these are patients whose depressive symptoms had been resistant to treatments with other kinds of medication and other kinds of treatments. And then finally, we have another biological intervention that is less invasive than electroconvulsive therapy and deep brain stimulation. So repetitive transcranial magnetic stimulation, or RTMS, uses magnetic fields, so similar to the technology that's used in MRI or fMRI, but these magnetic fields are used to stimulate brain activity. So this is a less invasive way of increasing brain activity to address depressive symptoms. So these are results from a study of 71 patients. These patients also had treatment-resistant depression. One of the reasons that RTMS tends not to be a first-line treatment and is used when individuals have not responded to other treatments is that it's a fairly time-intensive intervention. So this is done in a clinical setting. So you go into a room, you sit in a chair that's got a big thing that goes on top of your head. Often takes between 20 and 30 minutes to complete a session of RTMS. Makes a very loud banging noise. If you've ever done an MRI, you might be familiar with that noise. And often a course of RTMS, an individual will have to come in every day, so Monday through Friday, often for a month. So that's a pretty significant time commitment. So compared to other interventions like psychotherapy or antidepressant medication, it is harder to get treatment compliance. So often RTMS is considered for patients whose depressive symptoms are not responding to other kinds of treatment. So in this study, 71 patients with major depression whose symptoms had not responded to other treatments were randomized into one of three groups. The sham group in the blue line did not receive any treatment, but they got a sham treatment. So this was a blind trial and they didn't know what condition they were in. So they came in every day just like the other patients. They sat in the machine just like all the other patients. It made loud banging noises just like all the other patients experienced, but the magnetic field was not activated. So they were not experiencing the active treatment. The other two groups were randomized to receive RTMS, and this study was also looking at the efficacy of two different levels of intensity, so 80% and 100%. So they followed these individuals from pre-treatment through a week after the 1 month intervention. And what you can see is that the sham treatment group has a slight decrease in their depressive symptoms over that first week, but then their depressive symptoms remain high and stable. So they did not experience an improvement in their symptoms. Both groups who received RTMS experienced significant reductions in their depressive symptoms that continued to improve over time. And they observed the greatest improvement in depressive symptoms when the RTMS was administered at the more intense level. So RTMS, similar to electroconvulsive therapy and deep brain stimulation, appears to improve depressive symptoms by increasing brain activity. However, it can be a good option for individuals who want a less invasive treatment. So there are fewer side effects and fewer potential adverse outcomes compared to electroconvulsive therapy or the surgery that's involved in deep brain stimulation.